doing something a little different. Usually I talk about these markers more generically, but I do want to talk about the various ones. It's not going to be every single marker, but I've heard a lot at different conferences lately, oh, everybody's fascinated with serum markers. They go, why don't we just look at DNA in the urine? And the interesting thing is we've been looking for a lot of things in the urine for a couple of decades. It's not a novel concept to look for stuff in the urine when you have bladder cancer. It's just a question of what do you do with it. These are my interests. There's a bunch of different urine marker companies here, somewhere in there. So, I think we have to start with the basics. Why do we have a marker? We have clinical data. We want independent, impactful information. So it's either going to help us know more about the cancer outcome, regardless of therapy. Is this patient going to do worse no matter what we do? Or is it going to predict response? So will it tell us which drug we should give or how we should target a therapy? And those are sort of the essential hallmarks. And for non-invasive bladder cancer, is it going to make us detect cancers better than when we just look in there? We know that enhanced cystoscopy alone will improve detection, especially of CIS. Maybe we don't have to put a scope in patients as much. This is probably reasonable for low-grade disease. And we know cytology has problems. Some of it's been taken care of in the sense that we have less atypia now. But we miss high-grade disease. We don't even bother using cytology for low-grade disease. And there's nothing, more frustrating than having to call a patient a week after you look in the bladder, told them everything was fine, that they say, now the cytology is positive, and we got to go back and figure out, should we do biopsies? Should we do enhanced cystoscopy? Do we need to look at your upper tract again? So none of us really want to make that phone call. One of the issues that we really talk about, markers usually tell you sensitivity and specificity. That's not really what you care about. What you want to know is if it's positive, what do I do with it? If it's negative, what do I do with it? And that's really positive and negative predictive value. And this depends on prevalence. This is not sort of an implicit concept, but if you have a disease that's there 50% of the time, the positive is much more meaningful than a disease that's there 1 in 1,000 times. So I often, try to use analogies with patients, but the fact is the more rare a disease is, the less likely a positive is a true positive, and vice versa, the less likely that common a disease, the more likely a negative is a true negative. Now I'm going to talk a little bit about the markers. We commented on FDA approval or not. Most of these are not FDA approved, but they are commercially available. CX Bladder Monitor is a panel of RNA markers. It's actually designed as a rule-out test. It's important to kind of know how people are designing the test. What it means is that it's designed really to tell you if a negative is probably a negative, and yet when the test is positive, it doesn't mean you have cancer. So you can kind of take that out. And it's really been designed a little bit more to try to avoid cystoscopy in patients because if you do have a positive marker, it doesn't necessarily mean you have cancer. The test is just being modified now to add TERT and FGFR, which actually is improving its positive predictive value because it can detect more cancers that way. The GeneXpert is a test, the CFID. It's not commercially available in the US. It is elsewhere. It is another panel of mRNAs. Again, pretty good sensitivity and specificity. Its main benefit, it can get a report back in 90 minutes, but I don't think patients usually want to sit there for an hour and a half and wait to figure out stuff. Euromonitor looks at mutations in TERT, FGFR, and KRAS. You'll find that there's a lot of the markers use similar, of the different commercial tests use similar markers. So TERT and FGFR are common mutations, and multiple markers are using those mutations to detect disease. EpiCheck is one of the methylation markers. It's going through FDA approval right now in the US. It has a panel of methylation markers. I think Bladder Care is also doing that. There are just multiple publications looking at methylation changes, which are quite common. Has a good sensitivity for high-grade disease. Most of these markers kind of suffer when they start looking for low-grade disease. This one tends to have a little bit higher specificity. UroAmplitude is a little bit different. It's a next-generation sequencing. From a regulatory standpoint, it's actually interesting. Medicare views these completely different than other urine markers. They have all rules different for next-generation sequencing. But this provides a lot of information And if we have targeted therapies for FGFR, for example, this one could tell you if there's FGFR in the urine. It might be easier for you to get that than tissue, or at least quicker. And people are looking at these both as prognostic and predictive type markers. Oncoria is a protein multiplex looking at 10 different biomarkers, been validated in 3,000 patients. It's available now as well and looks at a variety of different pathways, and it's going through pivotal trials in hematuria and bladder cancer. And again, pretty high area under the curve, which basically correlates with a pretty good accuracy overall for detection. I don't have sort of a particular preference for any particular marker. We talked about the guidelines earlier. As you saw, there's very limited clinically validated roles for the biomarkers. We did 2 prospective studies looking at Eurovision for atypia, and then there was a study with CX Bladder. Eurovision is in the guidelines, CX Bladder not. It's not easy to know how that decision is made. But if you're looking at surveillance, which is the main thing that we do to try to detect cancer, you have to start thinking about it in terms of risk and where the markers might play a role. So for low-risk patients, we think that if you don't have cancer at 3 months, you really don't need to look for another 9 months to a year. So what are you trying to do with a marker to, reduce the frequency of cystoscopy when you're doing it once a year? I'm not really sure there's a good way to incorporate markers. For intermediate risk, the guidelines are kind of like look every 3 to 6 months. And so maybe you can look less often in the patients who have less likelihood of having recurrent disease. You kind of need patient-centric endpoints. We'll talk about that. There are some trials in this space. I think that, for low-grade cancers, the risk of progression is very low, less than 5% probably progress to more aggressive disease. The problem is markers don't really detect low-grade disease very well, and so unless you're looking for a high-grade tumor recurrence, you're more likely to have false positives, which will lead to anxiety and cost rather than detecting cancer. So there's some downside to potentially doing these types of studies. But nonetheless, this is an area of interest. There are a couple of trials. The UroFollow trial is one being done in Germany by Dr. Schmitz-Draeger. Prospective randomized trial comparing biannual marker with Eurovision and a P22. P22 is looking for basically a protein. It's a point-of-care test. Eurovision is a FISH assay looking at 4 different genes. And they're also using cytology, and they're comparing it to cystoscopy. They have 213 patients with low-grade intermediate risk disease, follows about 2.5 years. They have 102 patients in the marker arm, 111 in the standard of care arm. No significant differences in stage and grade. These are all low-grade TAs. And recurrence rates are very similar, around 30% in each arm. The marker missed 5 tumors. The standard of care missed 1 tumor. And there was only 1 patient that progressed to muscle-invasive disease. And so this was the first randomized trial that shows that you could reduce cystoscopy for low and intermediate risk disease, and that it was generally safe since they found the same number of tumors and almost no progression. So we'll have to see whether or not this actually makes into the guidelines. Florian Streck has a R1 grant to do a study called Replace Cysto. It's also focusing on low-grade intermediate risk disease. If you had a negative cysto at the first surveillance, then you get randomized 1:1:1 to expert bladder monitor EpiCheck versus cystoscopy. And the primary outcome, actually, you can't really power a non-inferiority study very well, so it's really a quality of life study to see if patients prefer to have a marker than a cystoscopy. And there's a stopping rule to find 4 progressors for muscle-invasive disease. As you saw in the prior study with over 200 of these patients, that happened once. So it's unlikely that this will be stopped because of lack of safety. The DaBlaCa study is actually a completed study being done. It's a Danish study. It's actually a study that I think is a little higher risk because they're doing it high-grade bladder cancer. And what you can see is that they're doing expert bladder monitor 3 out of 4 occasions, and only cystoscopy at 1 year and 2 year, as opposed to doing cystoscopy every 3 months. It's actually in Denmark. They're doing it every 4 months, I guess. I think most of us would, at least myself, would be concerned about not scoping these high-risk patients, but this is European views. And nonetheless, they did the study. It's a panel of mRNA markers, and they reported they're projecting to have 400 patients. And so far, they presented data last year. The paper is actually under review. I know that because I just reviewed it, but we'll see what happens. But I'll report on what they've reported, which is similar cancer rates in both arms, no difference in risk for cancer at 1 year, no difference in detection. So maybe for high-grade cancers that you feel comfortable, it's a safe alternative to cystoscopy. I don't know if I'll feel comfortable, even if the study is published, to suddenly adopt this instead of cysto. I feel more comfortable in the low-grade patients. So what are you going to do? I mean, I think the biggest question for us is that if you did use it in high-risk patients and the marker was positive, but you didn't see anything, what are you going to do? Because the positive predictive value for most markers is about 10 to 20%. And are you willing to biopsy these patients in the setting of a normal white light cystoscopy? There was a study that did exactly this, except it used a different marker. It used blue light cystoscopy as the marker and basically said if you had a blue light lesion, you need to biopsy them, even without knowing for sure that this was cancer. And, oh, sorry, I should go back. And so the interesting thing about that study, that blue light actually had a positive predictive value of about 60%, to 63 patients had cancer out of 103 patients who had a biopsy. So within that context of that trial, 40 patients went to the OR, had a biopsy, and it turned out to be a false positive finding. About 20 of them were patients who had an abnormal white light cystoscopy. So 20 were blue light, 20 were white light. So we do a lot of biopsies, even with normal cystoscopy, with white light cystoscopy that look abnormal. You see a red patch, you don't know what it is, and you say, okay, I'm going to biopsy this patient with a history. But this is the type of design you would need. Quickly going to atypical cystoscopy or cytology. When we scope a patient after BCG, there's often areas that look red or inflamed, but we don't know if it's CIS or not, because that's what CIS looks like. And so, depending on how anxious we are, how anxious the patient is, we say we should or should not biopsy the patient. It's just taking patients to the OR who are in their 70s or 80s, who have smoked and have diabetes and are overweight, is risky. Just being under anesthesia is a risk, rather than not just the biopsy. And so we would like to reduce that if we could. And so there were 2 prospective studies looking at Eurovision, and you can see that the PPV, which normally is around 10-20%, if you saw a red lesion and the fish was positive, the PPV was over 60%. The cytology was atypical and the fish was positive, the PPV was over 40%. But certainly a higher yield. And there was a second study, it was a validation study, and the PPV was 100% for high-grade tumors. So it's certainly a justification to go to the OR, and hence the guidelines have now suggested that for equivocal cytology and a positive marker, you should consider a biopsy. This is the study that Sia mentioned. There were over 1,700 patients, 153 had atypical cytology, and bladder cancer was found in 17% of them, but the CX Bladder test correctly adjudicated all of these. So you didn't have to biopsy 150 patients, but you really want to miss 26 cancers, so in a high-risk population. And so I do think that we need to, that this might be a valid role for markers, especially if there is some suggestion that maybe something else is going on. Here's the big rub on these things, is that normal cystoscopy is frequently wrong, and positive markers don't always yield cancer, especially if we don't biopsy it. So we have this whole terminology of anticipatory positives. We're starting to have that as well with our Natera Signatera testing. It's starting to go up. Do we feel comfortable changing therapy? The CT scan is negative. Well, we know that it could be a true positive, could be a false positive, and the anticipatory positive is there's microscopic or minimally residual disease, and is that really something we should act upon? And so this was a study that we did several years back looking at Eurovision assay in 150 patients who were BCG naive or going on BCG, and we tested the marker. And there were 46 events at recurrences by 9 months, 37 recurrences, 9 progressions. And here's what you find is that at baseline, the fish is positive. You're 3 times more likely to recur. Now, that's a PPV of about 40%, but are you going to not give BCG, or are you not going to continue to give BCG? The challenge, though, is that this is very good for populations, but not very good for individual patients. And so an individual patient with a positive fish may still not recur, and an individual patient with a negative fish may still recur. And so how to interpret this data, I find that it may make more sense when you're trying to enroll in the trials where you say, I need more events. Let me pick a population with more events, but it's very hard to inform a patient who you don't see cancer in right now that they should change therapy. In which case, it's not clear that the marker is that useful to you because really it's just more anxiety provoking, at least up front. These are patients that we're scoping every 3 months as already. Are we going to scope them every 2 months? Or, I'm not sure how to use that quite yet. So, there are some intermediate steps. We could do blue light maybe and try to find the tumor sooner, especially if we used white light to find CIS. Patients who haven't had imaging for a while, maybe we should at least consider it. I find that even at our center, when I look back, we talk about should we do it yearly for high-grade disease, but most people don't do it every year. Either forget to do it, or the patient has some mild renal insufficiency and we don't want to get an MRI, or we're not going to take them to the OR and do retrogrades if we can't find anything else. I think the final sort of thing is to, is there a mutational burden, that we could use, or are there certain mutations that might give us prognostic and predictive value? We're going to have potentially FGFR inhibitors. So some of the urine markers like this NGS one that Convergent has might give us some additional information that other markers don't. But it's going to take research and studies to actually confirm any clinical utility. So in conclusion, right now the guidelines recommend it in a few very specific areas. And the main issue is that we do need these randomized trials to demonstrate clinical utility. That's not enough to give you a marker, say this is how the sensitivity and specificity is. Go for it, good luck, figure out how you want to use it. And as far as prognostication and targeted therapies, we need to find if the drugs work, and then we can figure out if there's markers that are of value to detect these abnormalities. Thank you.
Yair, can you make a distinction between qualitative biomarkers and quantitative biomarkers? So one that gives you a continuous readout versus one that gives you a yes, it's there, or no, it's not. And I'll use it as an example, PSA. It's not a perfect marker. We've learned to use it. When the PSA is very high, like 50, there's a very high chance that there's cancer. When the PSA after prostatectomy is very low or begins to rise above a certain threshold, it's very likely that patient has, will have a recurrence somewhere. To me, the quantitative ones can be worked with in your own personal algorithm with your own patients to sort of keep moving the threshold of your negative and your positive value ratios to benefit you. Can you just comment on that?
Yeah, I mean, Sia alluded to this. One of the areas I've started to think about with all these novel therapies is that we have RECIST criteria for in oncology. If you had a patient with 10 lung metastases and you put them on pembro and they have 2 lung metastases, you declare victory as a medical oncologist. If you start with a bladder with 50% CIS surface area and you end up with 10%, you say this patient is not responding to the drug and we need to switch to a new drug. Most of these markers are not quantitative. Only the Convergent UroAmplitude has some tumor mutational burden area to it. You can blame the FDA for some of this because when Eurovision came out, more than 4 abnormal cells was considered the threshold, and then people did not report out. And if they weren't stuck with the FDA firm thing of setting a cutoff, same thing with NMP22, it was 10 units So for example, if you had 100 abnormal cells, the PPV might be 90% for Eurovision as opposed to 10% for 4 cells. And so because we don't have a standard where the marker can report out a gradation, so same thing with CX Bladder, it's a panel of 5 markers, it's a formula in part driven by age, which is weird because it drives a lot of patients into a positive just based on age for hematuria, for example. We would love the raw numbers and then some grayscale that said this is a very high PPV value and it's a very low PPV value, and then we might be able to act accordingly. We've been stuck with a black and white, which doesn't work well for markers similar to PSA. You know, if you use, you can use 4, and then there's a quarter of men with a PSA between 2.5 and 4 have prostate cancer. And if you use 10, then we wouldn't be biopsying 1.5 million men to find 200,000 men with prostate cancer, of which some are clinically insignificant. So, yeah, so it'd be nice if we evolved. We actually might devolve because of the way the FDA is mandating markers to move into a very cut point oriented area. And again, as I mentioned, next generation sequencing is its own thing. And so we might still be able to get some tumor mutational burden, and that may be of value to us down the road.
So yeah, that was a really good talk. We started the day today talking about upper tract urothelial carcinoma. Have you come across any urinary assay that is able to differentiate a bladder from an upper tract lesion?
Definitely not differentiate. There are some markers that they, in their cohort of 1,000 people or 1,700 people, they tell me, you know, they go, oh, we found 5 patients who had upper tract and the bladder was fine. And so there's anecdotal data in all of these very large data sets of patients with hematuria or surveillance for bladder cancer where the bladder was clean and the upper tracts were positive. Differentiating the two is not possible. It's only sort of anecdotal small patient numbers within large series of bladder cancer.
So to not put us too far behind, one more comment, and then we're going to just take a break, and then we've got a full afternoon here. So
just a quick question. How come NMP22 didn't take off? I remember having a lot of conversations with Bart Grossman that all you need is a test with a very high negative predictive value, and you could maybe avoid cystoscopy. So, I mean, essentially, can we just get a biomarker like that or something similar with a high negative predictive value and then do fewer cystoscopies?
This is going to be my expert opinion or inexpert opinion. Right around the time Bladder Check came out, it was a point of care, looks like a pregnancy test. It cost $18. Eurovision came out around the same time, was FDA approved, and was being sold the kits by Abbott for $50, and labs were making $1,500. So which test would you use? Then the company Matratech got bought by Alere. Alere is a company that focuses on point of care, mostly pregnancy tests, not bladder cancer, and they never did one more study on bladder cancer after they bought it. And mostly it's being used by gynecologists still, which is why it's still available, but almost no urologist is using it, and you make no money. You know, you can get $20 for an $18 kit.
I want to thank all the presenters and everybody for an amazing discussion this afternoon.